4 clinical quality measures for 2014. If you haven't participated in any of our other clinical quality measure webinars we've had, these are the list of remaining core measures, non-core measures outside of the recommended core measures that they've provided for both adults and pediatrics. Now, I stress the word recommended because although there is a recommendation that you choose those core measures that they've lined out, you don't have to do so if there are more relevant measures for your scope of practice. Okay? You must select 9 clinical quality measures covering 3 of the key policy domains that they've outlined. All of this information is available in both the Meaningful Use Clinical Quality Measure Guide that's available under the Help menu, as well as the Meaningful Use Stage 2 checklist we provided to all of our clients. This information can be found under the Help menu in ClinicsMD into the submenu of Meaningful Use. Select either Stage 1 or Stage 2. The checklist can be found here, which contains the full requirements for all the core and menu set measures, and also the 2014 clinical quality measures. And then it's also broken out by guides. You'll notice here that there's 2014 clinical quality measures. The guide is an overview of each of the clinical quality measures and how to document the information required in ClinicsMD to meet the measure. You'll also notice that there's a link for the clinical quality measure specification sheets that were provided by CMS. These are very useful as they contain the full information on how the information is being tracked, a full clinical rationale statement, as well as an improvement notation, which tells you what the percentages mean. In the core and menu set measures in ClinicsMD, you'll recall that there is a target threshold that you must meet. However, this is not the case for the clinical quality measures. So your percentages, your results, are dependent upon what is being tracked in the quality measure. In some of them, a higher score, in other words, a higher percentage, indicates better quality, whereas with other measures, such as the one that tracks high-risk medications in the elderly, a lower percentage is desirable and indicates better quality. These specification sheets, once downloaded, are in a zip file and look like this. You'll have the measure title at the beginning, the clinical quality measure number, and the version number. All this information is contained in ClinicsMD. It then goes in to state any disclaimers, the clinical rationale and recommendations for this measure, and guidance on how it is being tracked, including the initial patient population and denominator, and the numerator. There's additional information as it's broken out and tracking all the information contained in the measure. You'll notice this section here called Data Criteria, QDM data elements. This is especially important as we've provided a lookup tool in ClinicsMD for you to look up this information and see the exact data elements that have been used to track the specific items in the measure. For instance, any diagnoses, medications, lab results, radiology orders, they're all tracked by specific data criteria. These QDM elements with the corresponding value set ID that's highlighted on your screen will tell you how the specific data is being tracked by what measures. Okay? In ClinicsMD, you will find this lookup tool in the 2014 Clinical Quality Measures Dashboard Report. You'll notice that there is a button called Search Value Sets. Click the button to open up a search window. Type in the CMS measure number, and you can cut and paste that value set ID. And it would help if I enter the correct information. CMS 62. There we go. As you can see here, in this case, the diagnosis of HIV active can be tracked by ICD-9 codes or SNOMED CT codes. We've discussed how to map SNOMED codes to your ICD-9 codes in previous webinars so that both information will be pulled in. This is important for also the creation of those clinical document architecture reports that you can submit electronically through the direct messaging project in ClinicsMD. So SNOMED is used for both purposes. So in this case, an active status or diagnosis of HIV are tracked in ClinicsMD by these ICD-9 codes or SNOMED codes. Okay? I'll touch base on how to set up your provider defaults once you select your default reports that you want to track for your clinical quality measures. And those will be 9 reports covering covering 3 domains, 3 out of the 6 available. And they're broken out in ClinicsMD by the recommended core and non-core reports, and then further broken down into their healthcare domains: care coordination, clinical process and effectiveness, efficient use of healthcare resources, patient safety reports, population public health reports. All of those are your domains. Okay, so you'll need to select 9 clinical quality measures covering 3 domains. The provider defaults come in handy because you can go ahead and set those 9 default reports per provider. And once you're selected, they're done. You don't have to go back and constantly reselect the reports that you want to select for each report run. They're already defaulted. You just run your report, choose the frequency, and you're ready to go. The next beneficial feature is the ability to set up recurring reports. This is nice so you don't have to constantly set it for your providers every time you want to run the report. You can set it to run on a basis of daily, weekly, or monthly. Okay. Click the Add button, and it will, based on the provider selected, look to see if provider defaults have been used. If so, those are the reports that will be selected to run. You then took the date range. There's just some quick defaults available here: last 30 days, last 90 days, the full year to date, and then you can also set a specified date range. To set the frequency, you can set days. If you want it to run daily, to have a daily dashboard report of your results, just mark the checkbox. Otherwise, to set specific days of the week, uncheck it, and then manually select the days. There is also a monthly frequency. Quick selections are the first day of the month and the last day of the month, or specific day that you can set. Once this is done, your report will run automatically for you. You'll get a notification via a system message in your messages list letting you know that your report has been run and it's ready for you to review. And then results are displayed by provider. You'll also notice the Show Only My Requests. And this is because by default, you can see everybody's requests for report runs. So if there's multiple users in the system choosing to run these clinical quality measures and you don't want to see those, you can select Show Only My Requests, and it will filter the list. Okay? Once the report is run, it'll have a run status as completed. The date range is displayed, and the date it was run. Green status indicates that the target percentage was met on all reports. Red indicates the target was not met on at least one report, and yellow indicates the report run has not completed yet. If you recall, I'd mentioned just a moment ago that there's not a target threshold to meet for clinical quality measures, other than you have to have at least one in your denominator in order to report that measure. The numerators can be 0, but you have to have at least one patient in the denominator. So that is your target percentage for clinical quality measures in terms of the dashboard report and your either green or red status. Okay, so jumping right in, we're going to go ahead and cover the measures today, and then I'll also briefly touch base on using your clinical quality measure reports for your PQRS reporting for the 2014 year. The first non-core report is under the clinical process and effectiveness domain, and actually all of these that we'll be covering today are under that domain, is CMS 62, also known as PQRS number 368. And here's the spec sheet for that report. And as you can see in there, that this measure is tracking the percentage of patients that were seen in your report period with the intent of the treatment to be with a diagnosis of HIV or AIDS, seen within a 12-month period. Now, of course, your report period for 2014 will only be 90 days, so it will look for patients seen within that 90-day period, Q4, with a diagnosis of HIV or AIDS. The numerator are patients with at least 2 medical visits during the measurement year, so it'll go back the full year with a minimum of 90 days between each visit. The clinical recommendation for this measure is that clinicians should be scheduling routine monitoring visits at least every 4 months for all HIV-infected patients who are clinically stable. And the improvement notation is that a higher score indicates better quality. Okay. Moving on, next measure is CMS 65, also known as PQRS number 373, hypertension, improvement in blood pressure. The purpose or clinical rationale behind this measure is that high blood pressure is one of the most common risk factors for cardiovascular disease and stroke. And less than half of those with hypertension have their condition under control. Uncontrolled and untreated hypertension is associated with an increased risk for total and cardiovascular mortality among the general hypertensive population, which then puts a huge strain on the healthcare system as a whole and greatly affects patient care. The clinical recommendation for this measure is that treating systolic blood pressure and diastolic blood pressure to targets that are less than 140/90 is associated with a decrease in cardiovascular disease complications. The improvement notation for this measure is that a higher score indicates better quality of care. Patients that are excluded from this measure are those that have ESRD on or prior to December 31st of the report year. Documentation of dialysis or renal transplant also meets the criteria for evidence of ESRD. So if your patient has any of that information, those diagnoses in the chart, they will be excluded from the denominator of this measure automatically. The measure tracks all patients aged 18 to 85 years of age who had at least one visit in the first 6 months of the measurement year as a whole, who have a diagnosis of hypertension documented during that visit, and who have uncontrolled baseline blood pressure at the time of that visit. Again, your report period for this year will be only a 90-day period, Q4, and so for the initial patient population, your denominator statement It's going to be looking at patients that have seen up to 6 months prior to the start of your measurement period. Okay? Next measure is CMS 77, also known as PQRS number 381, HIV/AIDS RNA control for patients with HIV. In this case, the improvement notation is that a higher score indicates better quality of care. This tracks the patients aged 13 years and older with a diagnosis of HIV or AIDS with at least 2 visits during the measurement year with at least 90 days between each visit. The numerator are those patients who had their most recent RNA level as less than 200 copies per milliliter. So in this case, it's looking for a specific lab result value. In order for this to be tracked, the lab result values must be recorded into the Labs tab in Clinics MD. Scanning in results is not sufficient. There has to be a result of less than 200 milliliters. Next measure is CMS 122, also known as PQRS1, hemoglobin A1C poor control in diabetic patients. The clinical rationale for this measure is that diabetes is a group of diseases characterized by high glucose levels caused by the body's inability to correctly produce or utilize the hormone insulin, and is recognized as a leading cause of death and disability in the U.S. and is highly underreported as a cause of death. It also may cause multiple life-threatening, life-ending, or life-altering complications, including poor circulation, nerve damage or neuropathy in the feet, and eventual amputation. Clinical trials have demonstrated that improved glycemic control, as evidenced by reduced levels of glycohemoglobin, correlates with a reduction in the development of microvascular complications in both type 1 and type 2 diabetes. The improvement notation for this measure is that a lower score, a lower percentage, indicates better quality of care. It further goes on to state that frail older adults, which are defined as persons with a life expectancy of less than 5 years, and others in whom the risks of intensive glycemic control appear to outweigh its benefits, a less stringent target of 8% is appropriate. For all others, lowering the A1C to below around 7% has shown to reduce microvascular neuropathic complications of type 1 and type 2 diabetes. So therefore, for disease prevention, the A1C goal for non-pregnant adults is generally less than 7%. This measure tracks patients aged 18 to 75 years of age with diabetes with a visit during the report period, and for those whose most recent A1C level performed during the report period is less than 9%. Only patients with a diagnosis of type 1 or type 2 diabetes are included in the denominator for this measure. Diagnosis of secondary diabetes are not included. Okay. Moving on. Our next measure is CMS 122, excuse me, CMS 124, PQRS 309, cervical cancer screening, which tracks the percentage of women ages 21 to 64 years of age who have received one or more Pap tests to screen for cervical cancer. The clinical rationale behind this is that cervical cancer has a high survival rate when detected early, but it is the second most common cancer among women worldwide. The improvement notation for this measure is that a higher percentage equals better quality of care. Denominator exclusions for this measure are patients who have had a hysterectomy with no residual cervix. Those patients who have an indication of this in their chart will not be included in the denominator for this measure. The numerator are women with one or more Pap tests completed during the measurement period or within the 2 years prior to the measurement period. So it goes back a total of 24 months. It specifies that it is looking for a laboratory test result. It's not requiring a specific result of positive or negative, but it is looking for a resulted lab within the past 24 years before the measurement period ends. The next measure is CMS 125, also known as PQRS 112, breast cancer screening. This is the percentage of women 40 to 69 years of age who have had a mammogram to screen for breast cancer. The denominator are patients that were seen in that age range in the measurement period. Automatic denominator exclusions are those women who have had a bilateral mastectomy or of whom there is evidence of 2 unilateral mastectomies. The numerator are women with one or more mammograms during the measurement period or the year prior to the measurement period. So this measure looks 12 months prior. It clearly states that it's looking for a resulted mammogram order. Not a specific result of normal, abnormal, what have you, but it is looking for a completed and resulted mammogram order. The clinical rationale for this clinical quality measure is that breast cancer is the second most commonly diagnosed cancer among women after skin cancer, and after lung cancer it causes more deaths in women than any other kind of cancer, with an estimated 40,000 estimated deaths from cancer in 2010 alone. There has been a steady decline in breast cancer cases over the years, partly due to early detection using mammography. Deaths have decreased over the past several years, greatly in part due to early detection using mammography. And the estimates are that mammograms will detect about 80 to 90% of breast cancers in women without symptoms. The improvement notation for this measure is that a higher percentage equals better quality of care. Okay. Now to circle back around, I've mentioned in all of these reports a PQRS number. A feature of the 2014 clinical quality measures is that the specifications were provided for electronic clinical quality measures. It generates a unique file type when saved that can be used for your PQRS reporting via the QualityNet PQRS reporting portal. How this will work is that at the time of attestation for CMS Meaningful Use Incentive, you will indicate that you want to report your clinical quality measures along with your PQRS measures. Then you will use the file type generated by ClinicsMD, known as the QRDA, and report it along with your PQRS reporting no later than February 28th of 2015. You will then be able to successfully continue your attestation for your meaningful use incentive for 2014 by entering your results for your core and menu set measures. They will then wait and evaluate to see when you report your PQRS measures and will hold payment until after your clinical quality measures are received along with your PQRS report results. If you do not want to pull those together, because it does require a full year of data in 2014, so it will go back the entire year, you can choose to report your PQRS another way, such as claim-based reporting or registry reporting, and then continue with your attestation as normal for a 90-day period and attest to your clinical quality measures the same way you always have by just manually entering the results at the time of attestation. It is also possible to have separate measures for your clinical quality measure reporting and your PQRS reporting. If so, you still can use the reports generated in ClinicsMD for your PQRS reporting. You'll just report them separately. So you'll attest for your meaningful use incentive, enter your clinical quality measures at the time of attestation, and then go ahead and do your PQRS reporting by the end of February of next year using the electronic file output available in ClinicsMD. If you are interested in using the electronic format generated in ClinicsMD for your PQRS reporting, there are tip sheets for doing direct reporting on the CMS PQRS website. Information to include for PQRS reporting is the insurance payer type. This is something I covered during our very first webinar, which covered the setup features, and I'll stress the importance again. If you want to use the clinical quality measure file output for your PQRS reporting, you'll need to set the payer type for all your insurances in ClinicsMD. This information is required by CMS. Strictly for your electronic CQM and PQRS reporting. To set this information, select Settings and Health Plan in ClinicsMD. Select your Insurance tab. This is your master list. And on an insurance payer-by-payer basis, set the payer type. And it's broken out by your various Medicare types, Medicaid, TRICARE, and commercial insurance types. Okay. This is how they will track the Medicare patient data in the files that are submitted to them. As with our other dashboard reports and all the other clinical quality measures we've covered today, you have the ability to save the details for your report on our server indefinitely, one copy per provider. This is beneficial because although we strongly recommend that you keep the printed documentation such as reports for a period of 6 years after attestation in case you're selected for a post-payment audit, you may misplace this information. You can then retrieve it once it's saved on our server. An asterisk will then be displayed next to your report run to indicate that that snapshot has been saved. Again, only one copy can be saved per provider, so we recommend it be the final report run that you use for attestation or your PQRS reporting. To do so, you would just select the report. It will be highlighted and click the Save Details button. Just as with the other dashboard reports available for the core and menu set measures, you can look up the patients that fall into the denominator and numerator by clicking this magnifying glass icon to the far right of your results. This information is only available for all reports that are not saved for a period of 24 hours. So click the icon, and the first piece of information displayed are those non-qualified patients. These are the list of patients that are in the denominator that do not qualify for the numerator. This allows you to go and spot check your patients and see perhaps why they aren't following in the numerator like you think they should. Okay. Select the numerator radio button to view all the patients in the numerator, and same thing for the denominator, exclusions and exceptions. In terms of your results in Clinics MD, exclusions and exceptions are the same thing, and that the patient is pulled out of the denominator for that measure. They just break it out in the specs between automatic exclusions based on specific diagnoses and on case-by-case exceptions that you can report in the report exclusions tab in an encounter. That tab has been available since the initial 8.0 release that covered the stage 1 features. And then, of course, you can print these results or click Save As and export it to an Excel spreadsheet if you need to view the data in that format. So now I will open the floor up to questions. I've added in a lot of padding intentionally so that you'll have plenty of time to ask me any questions that you may have about the clinical quality measures in Clinics MD. So I'll give you a good 5 minutes to enter them in. In your webinar panel to the right side of your screen, you'll see that there's a section for questions. So go ahead and enter them in now, and I will get them and answer them in about 5 minutes, okay? Okay, doesn't look like we have that many questions today, so I'll go ahead and jump on those that I have received. The first question is regarding CMS 125, breast cancer screening. He said that it will calculate a numerator for results of a mammogram. Or does this need to be documented for clinics to pull correct numbers under radiology? Yes, it does need to be recorded in the radiology tab and be completed and resulted with as simple as a normal, abnormal result, whatever you have set up in Clinics MD. If you recall, during the Meaningful Use Setup webinar, and it's also available in the Setup Guide under the Help menu in Clinics MD, there is one step that you have to do in order for this to work. As I mentioned when I showed you the value set lookup tool available in Clinics MD and the corresponding data criteria for the data elements used in the report specs, this information isn't just pulling by specific radiology, radiology description. In this case, the radiology and even lab results measures are looking for a specific LOINC code. Those codes are attached to your orders in Clinic Setup. Okay? So for your radiology orders, you would add the LOINC here for the order itself. The specific list of LOINC codes acceptable for the measure are stored in those value sets. For example, let's toggle back to our CQM report. Let's search the value set for CMS 125. And there's a value set specific for diagnostic study results, mammograms. So in this case, they consider a resulted mammogram by these HCPCS codes if you are putting those charges in Clinics MD, or perhaps entering them in as a zero charge for your practice management system, or these LOINC codes, which are laboratory observation codes. Okay? So that's the full list available. Any one of these LOINC codes attached to your radiology order will insert the patient into the numerator for this measure. So these are the specific LOINC codes, those laboratory observation codes. And this is where they're set up for your radiology orders. In that LOINC field. Okay? Same thing for any order that's considered a lab order, such as your PAPs. You would attach the LOINC code to the result themselves. Okay? There's also a lookup tool available for you. So that's what these measures are tracking. Next question. What happens if you don't use the insurance in clinics for the electronic reporting for CQMs and PQRS? Would that option not be available? That is correct. For a valid QRDA file to be put out, it must contain, in addition to these other elements, at minimum the patient's ethnicity, the payer type, race, and the patient's sex. All those elements must be included in addition to the initial patient population information, denominator exclusions, and numerators. Specifically, that's how they track and pull out the Medicare patients, but they also want to look at and do use the data for patients as a whole. So specifically for your PQRS and CQM reporting, although they're most concern with your Medicare patients, they do want the information for all payers. Next question is a similar question for the QRDA format. You said that insurance payer type is needed for all insurances for CMS to identify Medicare patients. Is it possible to identify just 4 to 5 main insurance such as Medicare, Medicaid, Blue Cross, and leave the rest of them as others as unspecified? I haven't received any guidance, nor have I seen any information on the PQRS website about leaving your insurance types to the default, which is at this time unavailable, unknown. But I do know they are intending to use this to gather information. Unavailable, unknown doesn't have a specific payer type code attached to it other than 99999. In terms of it being a valid QRDA file, it would be valid because that code would be attached to the specific payers as the file is generated, if that insurance type is in the patient's demographics. But as you know, when CMS gathers this information, while again for the PQRS and CQM reporting, their biggest focus is on your Medicare patients and even Medicaid at the state level, it also helps them do comparisons across the board to see what types of care patients are getting based on if they have a government-sponsored insurance versus a commercial insurance, et cetera. That's why they want this information. Next question. If we're testing for MU2 for Q4 and want to perform a separate submission for PQRS, did you say that we can submit the numerator and denominator data for 9 CQMs without any need to generate and upload the QRD file to complete MU2 attestation? That is correct. If you're doing them separately, you would go ahead at the time of attestation and enter in your clinical quality measures results at that time, just like you did during stage 1. So you would select your 9 clinical quality measures during the attestation process and enter in the numerator and denominator information. Next question. So the only way to result the mammogram to count is to open a new encounter or reopen the encounter in which it was ordered. Yes, since it goes back a total of 2 years, you would need to reopen it. If they were never resulted in Clinics MD and never completed, you just have the order and left it out there. You would need to complete those in order for them to show up if it occurred within the past 2 years. So that patient would be counted in the numerator. Next question, can the data then be manually entered? I'm assuming this is referring back to the original question about the insurances. Yes, you can manually add the insurance types in Clinics MD. Here in the Insurance tab under Health Plan, this is your master list, as it were, of insurances, and attach the information here to your specific payer. So this can be manually populated. And then these insurance can be attached to the patient's demographics one at a time. Next question, it looks like my last one, is reviewing how to do the search value sets again. I will be glad to show this, as it is a great tool that we built into it. I've covered this in every measure regarding clinical quality measure, every webinar that we've hosted, just so I can place emphasis on this capability we've built into it. Let's take, for example, CMS 125. At the bottom of the specification sheets, which are provided to you in Clinics MD under the Help menu in the Meaningful Use submenu, you'll notice at the bottom a section labeled Data Criteria, QDM Data Elements. And it breaks out the information that's being tracked in both the denominator and numerator by its explicit definition. So in this case, since it's looking for mammograms, it's looking for a diagnostic study result mammogram. Okay? Coming down here to the data criteria section, you'll see here that diagnostic study results mammogram are identified using this value set. Okay? So you just do a copy and paste situation. In Clinics MD, you'll click the Search Value Sets button, enter in the measure number, and then cut and paste that value set ID. You can manually type it in as well. It's just much easier to do copy and paste, and then click Search. In this case, these are the value sets that are being used by CMS to identify, in this case, a resulted mammogram, either by one of these HCPCS codes or by a LOINC code attached to the order. Any one of these attached to the radiology order, the mammogram order, in clinic setup is sufficient to place the patient in the numerator if the mammogram is resulted and has one of these LOINCs attached to it, or had one of these HCPCS entered in their chart. Okay. And last question, can you provide the link to submit QRDA files to CMS for PQRS separately? It's via the QualityNet reporting portal. You can either, I can send this out, but you can quickly Google it. You can file it under the PQRS subsection on cms.gov as well. All the information is available out there on PQRS subsection of the cms.gov website, including things such as their PQRS reporting made easy tip sheets that they've provided using the direct EHR reporting file format, which is just using the electronic file formats generated by 2014 certified systems. Here's the document I'm referencing. I'll be more than happy to send this information out. This gives you step-by-step instructions on how to use that file format known as QRDA to report your PQRS if you so choose. Okay. Again, all this information is available on the PQRS site on cms.gov, and I'll be more than happy to send it out. Ooh, didn't mean to hit that button. Sorry, folks, about that. Any other questions for me? Okay, well, it looks like all the questions have been answered so far. If you have any questions that come to mind after today's webinar, please do not hesitate to send me an email. I can be reached at mary.brunson@clinicsmd.com, or you can send an email to mdclientsupport@clinicsmd.com, and I'll be glad to answer any questions you may have. I'll be sending out an email with some useful links for this reporting, including information on the PQRS website and their tip sheet that they provided, and some other useful links to help you along the way with your meaningful use stage 2 attestation this year. That concludes our webinar today. we have another one scheduled for this Thursday from 2 to 4 Central, covering the next 6 sets of non-core clinical quality measures available in ClinicsMD. So please feel free to attend that one as well. It's going to be covering a different set of 6 clinical quality measures. And you can also bring any questions with you to that webinar as well that we may not have covered today. Thank you so much for participating. I greatly appreciate it and hope to speak to you all again sometime soon. Thanks and have a great day.